And I hope these slides are visible and the laser pointer is visible. Is that right? Are the slides visible to everybody?
Yes, sir.
Okay, fine. So, so I'm going to start my timer now. So it's a 15-minute talk and I put the timer on now. So see, this is my talk, the vicious circle of diabetes, heart failure, and kidney function. When I first received the invitation, I thought, my goodness, what am I going to talk on it? Everybody knows it's a learned audience we are having. Everybody knows that these three are, as Professor Das was saying, in tandem. These also go in tandem with each other. And so what is there to talk about? Everybody knows about it. So today, the first bit, I'm just going to tell you the mechanistic bit, but the later ones, I'm going to dwell on two aspects which can break the cycle, the vicious cycle. One aspect, I think, was a bit of an eye opener for me, I must admit, and I'll share that with you. So we all know this, really. Type 2 diabetes ultimately may lead to heart failure, may lead to kidney disease. Both of them cause sodium retention, and both of them worsen each other. And not only that, heart failure may beget diabetes as well. So if you look at the effect of diabetes on outcomes in patients with heart failure, so the funny thing here is if you look at this, patients without diabetes, HFrEF, even they have less than diabetes with HFpEF. HFpEF on both the sides have got less chance of CV death. But diabetes with HFpEF has got a higher mortality than no diabetes and HFrEF. And of course, highest is diabetes with HFrEF. Now, 10-year mortality in type 2 diabetes by kidney disease manifestation. So it is very clear here, albuminuria by itself will raise the mortality. The impaired GFR will raise it even further. And both of them combined, 23 plus 17 is not 40, it becomes 47. So both of them combined increases it by leaps and bounds. Now I've come across this study, which had come only a year ago. Now we had studied one paper a few years ago, which showed the commonest presentation, cardiovascular presentation of diabetes was peripheral arterial disease. So this is a more recent publication in a large multi-cohort study of more than 1.1 million, so more than 11 lakh patients across several countries in England, Germany, Japan, Norway, Sweden, etc. And what they tried to see was examining the manifestation of cardiovascular or renal disease, CVRD, in patients with type 2 diabetes who were free from CVRD. And it was more than 1.1 million patients. Now, look at this. Forget all these other countries. Just look at the total. So if you see the commonest manifestation here was not the peripheral arterial disease, which was there in the previous publication. Mind you, the previous publication looked at data before 2010. This was data from 2010, when all the modern treatment had come into play. And here you can see CKD was 36%. And heart failure is 23%. So if we combine both of them, it takes the major part of the cake. So more than 50% will be a combination of these two, while a stroke, MI, and peripheral arterial disease follow later on. So compared to CVRD, cardiovascular renal disease free state, single presence of heart failure was associated with increased risk of CKD, that is twice, 2.3 times, and CKD was associated with increased risk of heart failure about 2 times. So both worsen each other. Now, so as far as heart failure is concerned, diabetes we know is associated with high blood pressure, is associated with dyslipidemia. Both of them accelerate atherosclerosis, leading to heart attack, and that may itself lead to heart failure. Type 2 diabetes may lead to prothrombotic state, which again may lead to heart attack and heart failure. Microcardiovascular disease. So that's a new terminology which has come up. It's not only just macrovascular, it's microvascular affecting the heart. That may ultimately lead to dilated cardiomyopathy and heart failure. And so heart failure itself can cause the blood sugar to go up, and the blood sugar going up can lead to heart failure. How? So if you have got pancreatic insufficiency and insulin resistance, ultimately the insulin resistance will begin to drop. Then high blood sugar will lead to advanced glycosylated end products, free radicals, lead to fibrosis and HFpEF because of LV restriction. You have got microangiopathy, you have got inflammation, all of them, along with myocardial necrosis. Along with all of this, will need to have ref. The heart failure itself will cause sympathetic overactivation that will increase the lipolysis, RAS activation, that will also lead to insulin resistance. So insulin resistance meaning not allowing insulin to work, insulin hypersecretion, and then ultimately the hypersecretion leads to insulin failure. So the vicious cycle continues. The heart failure itself, with this sympathetic RAS activation, might adversely affect the kidney by causing vasoconstriction and reducing the glomerular filtration rate. So that is heralding the onset of CKD. So both of them can lead to anemia as well, which might worsen things further. So the vicious cycle continues. We have to break it somewhere. We have to break it somewhere. But actually, we just keep focused on this sort of circle. We fail to sometimes appreciate that there are a lot of other things which is keeping this circle going. So blood pressure, very important, often ignored during our consultation because we are so focused on the blood sugar itself. We're so focused on finding whether the patient has got heart failure or not that we fail to appreciate that the blood patient has been running slightly high blood pressure. Lifestyle, smoking, lipids, all these are vitally important in breaking this vicious cycle. But today I'm going to just focus on two other things. And one of them, as I said, was an eye-opener for me. One is iron deficiency, and the other one is obstructive sleep apnea. Now I'll tell you about iron deficiency because this is again another vicious cycle. Anemia begetting renal impairment, worsening renal impairment, worsening heart failure, and all of them worsening each other. So iron deficiency affects up to 1/3 of the world's population and even more in our country. And people at high risk include the younger population and also the elderly population. Now, I was struck by the amount of data with heart failure studies. And this is the ones which have got completed studies with iron treatment. Now, if I have not on purpose shown you the studies which are recruiting patients, because there are equally in number, if not more, studies which are being recruited to see the effect of iron treatment in heart failure. Now here, if you see, most of them are with intravenous iron, some of them are with oral iron. Unfortunately, oral iron treatment has not shown much benefit. But here, if you look at the hemoglobin, not necessarily they are all very anemic, inverted commas. You can see here, this inclusion criteria is hemoglobin less than 15 only, and this is less than 15. Some are less than 12.5. Some are between 8 to 13. So not necessarily anemic, if you see my point. But yes, anemia is definitely there. And now if you look at the effects of intravenous iron deficiency iron therapy for systolic heart failure, and this is the meta-analysis of the RCTs. If you look here, the all-cause death or cardiovascular hospitalization, there is about 60% reduction. Cardiovascular death or hospitalization for heart failure, and look at heart failure hospitalization. We keep talking about, SGLT2 inhibitors in and out, but look here, this is just a simple iron treatment, which has reduced it by, close to, 70, 80%. This is the amount of reduction that you're getting. So that's quite amazing. And this is not just for patients who are severely anemic, but that should open up our eyes. At least we should strive and look and exclude anemia. That's very important, I feel. And this is the latest which has come out from, this is the heart failure journal. So if you look here, for iron treatment, no underlying illness, we use ferritin less than 30. But for chronic heart failure, transferrin saturation less than 20 or ferritin less than 100 if the transferrin saturation, ferritin between 100 to 200, 300 if the transferrin saturation is less than 20. So these are all the others which are there. So if you look at this article, which clearly outlines how we should go about giving iron IV. So symptomatic HFrEF, NYHA 224, yes, symptomatic HFrEF. Hemoglobin, is it less than 15? Yes. Then is ferritin less than 100, or ferritin is between 100 to 300, but transferrin saturation less than 20. If you satisfy this criteria, you consider IV iron treatment. And I've shown you the evidence, what it does. And therefore, it has made its way into the guidelines as well. And you could say ferric carboxymaltose should be considered for iron deficiency, class 2A and level B evidence, which is actually better than these three recommendations as well. So that's an eye-opener for me. I really want to know from the cardiologists in this meeting, do we really give IV iron treatment if the evidence is that good? So the other one is the obstructive sleep apnea, and for population estimate for mild to moderate is between 3 to 28% for mild and 1 to 14% for moderate. So estimated 1 in 5 adults have mild OSA at least, and 1 in 15 have got moderate. So if you look here, the relation between obstructive sleep apnea and heart failure. So here for HFrEF, you can see here prevalence of OSA in these studies, and this is apnea hyperapnea index more than 15. That is very severe obstructive sleep apnea. You can see the percentage of patients who have got this in patients with HFrEF. And mild to moderate, look at the high, almost half of them in some studies have got mild to moderate obstructive sleep apnea. That's how important OSA is. And not only in HFrEF, even in HFpEF, we have got 35 to 65% of patients who have got obstructive sleep apnea. And leave alone that, if you consider sleep, CKD, diabetic kidney disease. So again, urine albumin creatinine ratio. So more the obstructive sleep apnea, more is the urine ACR. Lower the GFR. So I'm coming about lower GFR, more severe is the OSA. So that's the link the OSA has between heart failure and the DKA. So this is another simultaneous vicious cycle going along with the iron deficiency anemia that we should all strive to break. And OSA, I'm afraid, is very badly missed and underreported and undertreated. So we know that with the SGLT2 inhibitors, and this is a welcome change, in the EMPA-REG trial, we have got 52% lowering of the risk of new onset OSA. And this was not attributable entirely to the weight loss. And I will tell you why. So only part of it, the 25% of it were attributable to weight loss. The rest was something else. This is new onset OSA. What about patients who already have got OSA? So we have got data with dapagliflozin, where dapagliflozin studies, post-treatment studies, you can see the ESS score has improved, the oxygen saturation has improved, whereas in the controls, there is no change. So if you don't have OSA, it prevents you from becoming an obstructive sleep apnea patient. If you have got OSA, it improves your oxygenation and sleep score. So this is one of the postulations given, is that the SGLT2 inhibitors reduce the interstitial fluid more than the intravascular volume. So the blood volume, this is the SGLT2 inhibitor, and this is the diuretic. So you can see here the diuretic reduces the blood volume much more than the SGLT2 inhibitor. But the interstitial fluid is almost similar reduction. So the amount of interstitial fluid reduction in relation to blood volume is much more with the SGLT2 inhibitors. So if I show you this in a cartoon, that's easier to explain. So this, you have got a patient, edematous patient, where there is interstitial edema here. Now with the diuretic, loop diuretics here, you're reducing the interstitial edema to some extent, but you're reducing the intravascular volume also to a significant extent. But with the SGLT2 inhibitor, you're not reducing the intravascular volume to that extent, but you're reducing the interstitial edema significantly. This, I feel, has an impact, because when trials have been done using diuretics in obstructive sleep apnea, they have had mixed results. This is simple, because when you are giving the diuretic, you're reducing the intravascular volume. When you're lying down flat, the blood again goes up to the neck, and the interstitial edema worsens the OSA. But with the SGLT2 inhibitor, that reduces the interstitial edema, whether you're lying down or you're sitting up. And that's probably why it has a brilliant impact on OSA incidence and worsening. And I have asked a few patients, and I wish all of us together can do an observational study at least to find out the impact in Indian patients with the SGLT2 inhibitors and OSA. So many patients I have asked who I felt had symptoms of OSA, and many have said that they feel a lot of improvement in their sleep quality, and their partners say that the snoring has got better after the use of the SGLT2 inhibitors. So coming to the last few slides, my time is up. I'll just take 1 or 1.5 more minutes. So this is one article which had come up just a year ago, which they said that nowadays we have got an armamentarium of these drugs, ARNI, beta blocker, aldosterone antagonist, and SGLT2 inhibitor. If we use this versus the older conventional therapy, which is ACRB and beta blocker, how much benefit are we getting? So they compared, they took the emphasis paradigm and the DAPA heart failure studies to base their judgment, and they've said that these 4 together is way superior than the ACRB and the beta blocker combination. Now, but mind you here, this SGLT2 inhibitor also has a beneficial effect in the renal impairment as well. So event-free survival, that is heart failure or cardiovascular disease survival, event-free survival is about 8 years. So you're giving the patient 8 more years of event-free survival. And if you're looking at a projected survival, just survival, so you're giving extra 6 years of survival, because you're breaking the vicious cycle, at least on one leg, which is the heart failure bit. And with the SGLT2 inhibitor, you're breaking the kidney bit as well. So this is my last slide. Oh, sorry, second last slide. So if you look at CKD1 and 2, CKD3 and CKD4 and 5, so I've said the relative strength of goal-based directed medical therapies, you can see you've got a lot of agents in this region which have got strong evidence, which is beta blocker, the spironolactone, the ARNI, and the ACE inhibitor, ARB, and of course SGLT2 inhibitor here is missing. But here in CKD4 and 5, apart from beta blocker, we have very weak evidence or no evidence with the other drugs. So we still are struggling to get evidence for CKD5. So now, with this vicious cycle in mind, the newer recommendations are coming, and I'm sure in the future, instead of MACE, we'll get MARS, which will include acute kidney injury. So we now have stroke, myocardial infarction, and death. And now we have stroke, myocardial infarction, heart failure, and death. And now in the future, we'll have acute kidney injury, dialysis, progression of CKD, and the others. So that will be MARS, which I think is a fair comment to make. So I think we have to constantly look out to break this vicious cycle, not just focus on the blood sugar only or heart failure only. We can intervene in multiple levels, blood pressure, lipids, lifestyle, but look at other facets, anemia and OSA, which I've just highlighted. I'm sorry I've taken 2 minutes extra. Thank you for your patient listening.